This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I interview Dr. Chris Showalter to talk about the Maitland approach. We discuss various aspects of the Maitland approach, including Chris' personal experiences with Jeff Maitland, key principles, assessment and treatment, manipulation versus mobilization, as well as a comparison with other renowned approaches like Mulligan and McKenzie, and much more. Dr. Showalter is the co-owner and clinical director of MAPS and the program director of the MAPS Orthopedic Manual Therapy Fellowship Program. Chris has taught skill orthopedic manual therapy through MAPS in the US and internationally since 1990. And he is also an board-certified orthopedic clinical specialist and a fellow of the American Academy of Orthopedic Manual Therapists. If you find this information valuable, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share with other clinicians who could benefit from this information. Thank you for tuning in, and we hope you enjoy the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Hi Chris, welcome to PT Pro Talk. How are you today?
Hey Mariana, I'm great. How are you? Thanks for having me on.
I'm great as well, so I appreciate your time here. And let's get started talking a little bit about yourself and your background, your career, for the ones that don't know you.
Sure. So I'm located in New York in USA. I'm a dual national, US and Australia. I spent the age from 8 till 28 in Australia, and I did my first degree was a Bachelor of Science in Reproductive Physiology of Sheep, which has nothing to do with my Bachelor of Applied Science in what's called in Australia physiotherapy, which I graduated in 1987. So that's more years than I'm willing to admit to. I was fortunate to be able to do some graduate work in South Australia, in the city of Adelaide, with Jeffrey Maitland. And even though the Maitland approach was employed within the undergraduate system, it really didn't click with me until I spent some time with Jeff. And then that really changed my world. I'm a PT, DPT, Doctor of Physical Therapy, OCS, Board Certified Orthopedic Clinical Specialist. I'm a fellow of the American Academy of Orthopedic Manipulative or Manual Physical Therapy, or FAAOMPT. I've been very active at the US national level. I was the chair of the International Affairs Committee for 10 years. I was chair of the conference committee for about 4 years. I was on the governing board of examiners for a number of years. I was the 2009 McMinnell Award recipient for service to the Academy, and I currently serve as Chair Emeritus to ACOMPTE, the Accreditation Council on Orthopedic Manual Physical Therapy Education. ACOMPTE is the group that accredits fellowship programs in OMPT, Orthopedic Manual Physical Therapy, in the US to meet and in some instances exceed IFOMPT standards. IFOMPT is the International Federation of Orthopedic Manual Physical Therapists. I was the US delegate there. It makes sense, I'm Australian, right? I'm American, but I got this funny Australian accent. So from 2000 to 2009, I was the IFOMPT delegate representing the US on the international stage. And I currently serve on the advisory group on membership development at IFOMPT. So that's a group which helps early developing programs that want to become a member organization of IFOMPT. So we help them with their standards, with their constitutional documents and other things, and help them meet the international standards to apply as a member organization of IFOMPT. So that's about me. I teach orthopedic manual therapy through my company, which is called Maitland Australian Physiotherapy Seminars, named after Jeff Maitland and other prominent Australian physiotherapists. And our website is ozpt.com. That's my last promo. So that's me. What else do you want to know?
What an amazing career. Oh, my goodness. That's very impressive. And what I want to know more about your time first with Maitland. So how long did you had the privilege of spending time with him?
Oh, sure. So I actually spent about 3 months with him studying, and then went back sometime a little while later, and we actually opened a small practice together, a clinical practice. So yeah, total time was probably about 14 months. But I have a good understanding of what Jeff's principles were. And most important, number one, and I really want to talk about that and emphasize that today, was his empathy for the patient. Jeff's first principle, number one principle of patient management, like the First Amendment to the US Constitution, that the therapist perform a sublimation of self and develop an empathetic understanding of what the patient is enduring and how it's affecting that person's life. It wasn't about biomechanical principles. It wasn't about other issues. It's about the patient. The Maitland approach, along with a couple of others, are the original progenitor patient-centric approaches. And they have been so in the Maitland approach since the early 1960s. You know, Jeff was born in 1926. He passed away, unfortunately, in 2010. During World War II, he was a Lancaster bomber pilot running night missions over enemy territory out of England. He was a visionary PT. He was a co-founder of IFOMPT along with Stanley Paris, Freddie Kaltenborn, and Gregory Grieve. His empathetic, and this is a quote you'll often hear about Jeff Maitland, his empathetic, patient-centered, unremitting clinical assessment approach has been widely adopted around the world. You know, we call our company Maitland Australian Physiotherapy Seminars. When I spoke to Jeff, when I returned to the States in the early 90s, and I said, look, Jeff, you know, I want to teach you stuff here. And he said, yeah, I think you should. And I partnered up with a gentleman named Bob Sprague, who had already started teaching, who also studied with Jeff. And Bob actually became a very close friend of mine, and I actually gave the eulogy at his funeral, a very, very close friend. Bob had a different name for the company, and it didn't sort of make sense. It was called CPEA. It really didn't say anything. So I went to Jeff and I said, Jeff, you know, what I'd like to do is I'd like to call this the Maitland approach. And he said, absolutely not. And I said, why not? And he said, because it's not just about me. I said, Jeff, it's the early 90s. You've got to understand, everyone wants to get their Mulligan, their Maitland, their McKenzie, their Paris, their McConnell. You know, it was all guru-based then. It was all based upon the person and their reputation. And he said, no, you're not going to name it after me, because he was a very humble man. I said, how about Maitland Australian? And he said, yeah, I can live with that, because it's important that the input of the other people who are involved in this approach are recognized. So some of those people that your listeners may or may not have heard of, depending upon their age, obviously, are people like Bob Elvey, who developed the upper limb tension tests, they were called, ULTTs. They're now the upper limb neurodynamic tests. Gwen Jull, who's chair emeritus at University of Queensland, she did seminal work in cervicogenic headache, cervical spine, clinical reasoning, lots and lots of wonderful output from her research group. Brian Edwards, who put together combined movements. So when you see combined movements being used, thank Brian Edwards for that. Jenny McConnell, who I've already mentioned. Michael Shacklock and Dave Butler in the world of neurodynamics. And can't not mention Mark Jones and Darren Rivette for their seminal works in clinical reasoning and clinical assessment. So, that was my time with Jeff, and then coming to the States and teaching in the States. What's next?
We had it here on the podcast, Gwen Joe and Michael Shacklock. So I guess those two people might be familiar.
Yeah, Michael's a very good friend of mine.
Very nice. And I think what was amazing is like we had this close contact, so we can really stay true to the principles and pass them along. So I think that's very good that you have someone that spent time with him being the leader here in the US and staying true to the principles, right?
Well, that's really important, right? Oscar Wilde said that imitation is the most sincere form of flattery. Okay. Another way of saying that is originality is the ability to conceal one's sources. Apparently that's anonymous. I don't think it's anonymous. I think someone actually wrote it, but everyone says it's anonymous because that's the humor involved, right? Originality is the ability to conceal the sources of where you got the original idea, right? So, do you get the pathos there?
Yeah.
So, Maitland had some wonderful truisms, and one that is sometimes quoted is when they asked Maitland. So Maitland was asked one time, so what do you think about this Maitland approach? And he said, you know what? There's so many people trying to do Maitland these days. I'm not sure I'm even doing the Maitland approach right. But an important quote from Jeff, which I'd like to share with you, is that he said that regarding the Maitland thought process, and he said it's an open-mindedness, mental agility, and methodical process of assessing cause and effect, which are the demands of the concept. I don't have a year on that, but I've heard him say that a number of times, and I've seen it a number of times. So open-mindedness, mental agility, and mental discipline with logical, methodological processes of cause and effect. See, the Maitland approach is very scientific. If you think in terms of science, okay, you have a hypothesis. And what you do is you take a look at the dependent variable, you change the independent variable and see what happens to the dependent variable, right?
Yeah.
And thus you confirm or modify or reject your hypothesis. Every Maitland therapist who treats a patient does that every time they treat them. If someone has a neck problem and I do some sort of intervention, what I start out with is a subjective pain score. It's a 4 out of 10, and a limitation in movement. I can't move my neck to the right, for example. And then I do my intervention, the independent variable. And then I immediately set them up and say, okay, where's your pain? It's gone down to a 1. How's your movement? It moves more and it doesn't hurt as much. Great. So we've confirmed that hypothesis we had on that patient based upon immediate assessment of results of the intervention we gave them.
Yeah. And
does that make sense?
Yes. And it's very similar. We were talking about that before, very similar with the McKenzie thought process in that sense too. So I'm very curious to ask you about the assessment. So everybody talks about the Maitland assessment. So in the importance of the assessment, would you walk us through how assessment would look like?
Sure. So, I said Maitland's number one principle was an empathetic understanding of what the patient's enduring, okay? So we begin, a typical Maitland, this was drilled into me by Jeff, is the following question. First question, hello, Mariana, how you doing? Come on in. Let's talk about what's going on. Mariana, as far as you're concerned, what do you feel is your main problem? It's an open-ended question. It's directed patient-centric to the patient. It doesn't say, what does your MRI results say? It doesn't say, what did your last clinician say? It doesn't say, what did the doctors say? It says, I want to know what you think's going on. And often you find some really interesting anomalies. I've got pain in my elbow. They just keep injecting it and it's not getting better. And I keep telling them that when I turn my head that way, I get the pain in my elbow, right? That was just really meaningful to me as an orthopedic manual therapist, and a sad indictment on the way some practitioners practice. No labels, that's not important. So the examination begins with a subjective examination, the history taking. But the history taking is an active history taking. I'm not checking off boxes on a form. I'm not filling out something in the computer, in the electronic medical record to submit to insurance companies and stuff. I'm trying to understand what's going on with this patient. And so I start with that original open-ended patient-centric question. And what I want to find is something called the comparable sign. The comparable sign is any posture or movement, either patient-generated or therapist-generated, which most closely reproduces the symptoms the patient complains of. So it's a comparable sign, that is, the movement is the sign. The comparable comes from it recreating their symptoms as exactly as we can. So, for example, if the listeners and viewers can watch, so, very typical to see a patient with shoulder pain say, ow, that hurts. Where does it hurt? It hurts there. I'll turn a little bit so you can see. It hurts there. Is that your problem? No, it's not. Well, what about if you do hand to the side? What happens when you do that? Yeah, that hurts too. Is that the one that bothers you? No, it's not. Well, can you show me what bothers you? Yeah, well, it's kind of weird, but it's something like this. I come up there, I do that right there. That's where I get my symptoms, right there. That's the comparable sign. These other things are relevant, but they're joint signs. They're lower on the hierarchy compared to the actual movement that the patient gets that recreates their symptoms. And that's very informative to us.
Yeah.
Part of our assessment considers the patients into two broad groups: those that are pathophysiological, which are essentially what Maitland called pain dominant, and those that are pathomechanical, which Maitland called stiff dominant. In the pathophysiological group includes other issues that weren't being considered at the time when Jeff first wrote. So that includes nociceptive, nociplastic, that includes central sensitization, that includes the cognitive behavioral therapy and other psychological components of the biopsychosocial nature of the patient's disorder. So if you think of it, if you look at my hands and they represent a funnel, we start up the top in the subjective examination and we get an idea from the patient what's causing their problem. Then the patient does, coming down the funnel, they do active physiological movements. And if they're clear and pain-free or there's minimal pain, we can do overpressure to them to see if we can reproduce the pain with overpressure. So, subjective exam, active physiologicals, APMs, right? Active physiological movements. Then passive physiological movements, PPMs, okay? The PPMs that we look at, because there's never enough time to look at everything in every potential patient. The clock is always your enemy. So in the initial treatment session or assessment and treatment session, the passive physiological movement we would do would be those that were meaningful in the active physiological. And then finally, we end up with passive accessory movements, PAMs or PAIVMs, passive accessory movements anywhere, passive accessory intervertebral movements when it's applied to the spinal segments. At each point in that assessment, I'm looking for reproduction of the patient's comparable sign. If I can produce it in each movement, then I have lots of options. If I can reproduce the comparable sign in active physiological movement, right rotation, I could give that to them as a home exercise. If I can do it in passive physiological movement, I could treat them with passive physiological movement. If I can do it with my fingers and thumbs over a particular joint or a particular spinal segment, then I could treat that. As I assess down the funnel, and this is the way I teach Maitland these days. This is it's based on Maitland, but it's my own sort of input, my own thought process. Then what I do is I treat at the bottom of the funnel the passive accessory, okay? The arthrokinematic equals accessory, osteokinematic equals physiological, right? The arthrokinematic movement, because in changing arthrokinematic movements, I can quite often immediately change the passive physiological and the active physiological. Does that help?
Yes, no, you just said a lot of things. So the idea is to start with the passive to then be able to go back to the active and improve the pain while the patient is doing whatever the movement that it hurts, if it is active. And if you don't find active, just passive, you just compare it passively. Is that correct?
Yeah. So every time I reproduce the comparable sign, I have an option for treatment or intervention, right?
Mm-hmm.
Let me ask this is a rhetorical question,
Mm-hmm.
which means that you don't have to answer it. And for your viewers and listeners, which muscle can move the L4 vertebrae, lumbar 4 vertebrae, translatory, pure anterior? And for bonus points, you could give us the nervous innervation and the lymphatic drainage. I'm joking, right? What muscle can move L4 anteriorly? Pure anterior, not flexion, not extension, side bend, or rotation, pure anterior. You know the answer, I know the answer, and most of your listeners know the answer. There is no muscle that can do that. Similarly at C4, what muscle can move C4 anteriorly? Pure anterior translation. In Maitland, we talk about starting position and ending position. So if I was going to do what's called a central PA, a central postero-anterior on the L4 spinous process, and I'd use a grip kind of like this. If I was going to do that, I would call it a CPA, central postero-anterior, starting posterior, going anteriorly. Those arthrokinematic movements, and this is pretty much a truism of most biomechanical theory, that you cannot have full osteokinematic or physiological movement unless you have full arthrokinematic or accessory movement. So a lot of Maitland therapists realize throughout their careers that just go to the heart of the matter and correct the accessory problem at the bottom of the funnel, and then reassess the passive physiological and reassess the active physiological. Does that make sense?
Yes. And that should be like a shorter cut to then, just because my brain works a little bit more on the McKenzie, that's what I've been. So I'm just here processing the information. So I guess what you're doing is trying to help the active movement get better quicker by helping the joints to move on the position they need to move to then respond to the active.
To the other interventions, right?
Mm-hmm.
To the active interventions.
Mm-hmm.
So what upsets Maitland therapists? Oh, you're a Maitland therapist. You're a joint jiggler. You just push till it hurts. How do you upset a McKenzie therapist? You say, oh, so everyone's just got to do lumbar extension, right?
Mm-hmm.
Yeah, that gets a burr under everyone's saddle, right? But let's say we've got a patient, okay, and full disclosure, I spent a number of weeks in New Zealand studying with Robin McKenzie before I went to train with Maitland. That is, I wrote him a letter. For the younger people on this call, there was no internet, there were no emails, there were no Zoom calls, there weren't even cell phones. You had a rotary phone that you dialed, and I didn't have his number, so I wrote him a letter. And I said, I just graduated PT school in Melbourne, Australia. Can I come and see what you do? And he said, sure, come on over. And I went over to him, and I was staying in a very cheap hotel in a, let's call it a disreputable part of town. And the original idea was I was going to be there with him for 3 days. And he said, where are you staying? I said, I'm staying such and such. He said, you what? No. Don't stay there. He said, you come and stay in my spare room. I said, you're kidding. He said, no, come on. I said, all right. So I went and stayed in his spare room. And we ended up doing that for about 3.5 weeks. So I have a really firm understanding of the original McKenzie concepts. Yeah. But let's go back to this thing about passive accessory movements, arthrokinematic movements, and why they're important. Let's say we've got a patient who is applicable for McKenzie, and he blew out a disc, say, 18 months, 2 years ago. Typical sort of profile, muscle relaxants, non-steroidal anti-inflammatories, rest at home until it calms down, use ice if you got spasm, right, from our medico friends. And never really got to a manual therapist or a McKenzie or Maitland or Paris or Mulligan or whatever trained therapist. And so that resolves and it settles down, but 18 months, 2 years later, he has a reoccurrence of it, right? And he comes to a Maitland trained therapist. So a Maitland trained therapist is going to do that assessment through the funnel that I talked about. And then what you're likely going to find at that level is hypomobile, okay? Now, palpation of movement is quite variable, okay? It's not very good, okay? There's a great deal of variation. With my 35 plus years of palpation, I'm pretty good at intra-therapist reliability, but the reliability between me and other therapists depends upon their experience too. So if you compare my 35 plus years to a first year PT student, day one at school, palpate the L4 movement, it's going to be pretty variable, right? And that's not a value judgment. That's just life. Life is experience. And the more you can rack up, the better you get at it, right? So back to our patient who has a limitation in extension, for example, right? We'll call him an extension biased patient. But he's got this old injury. So if we just gave him extension, how likely is it that the L4 segment is going to move? It's probably unlikely. I'm going to leave you off the hook, Mariana, and not ask you to make a comment. This is my statement. It's probably unlikely that in an adhesed, potentially scarred down back, that it's probably not going to move. And we could do extensions out the wazoo all day long, and we're going to get movement above the level and movement below the level, but likely not get too much movement at the offending level. What the Maitland therapist would do, what I would do with my Maitland and McKenzie, is I would mobilize central PA on L4 to restore movement at L4 using the comparable sign. When I push on that, what do you feel? Yes, that's it. That's my pain. Great. So I'm going to mobilize it in a certain way using a certain grade of movement, yada, yada, yada. Now get up. Now let's see what you can do in extension. So now that L4 has a chance of moving, right? So the two are not combative. The two, McKenzie and Maitland, are complementary. My problem becomes that this is going to get controversial, but that's okay. In certain parts of the world, I'm not even going to say the McKenzie Institute, okay? I'm letting them off the hook. McKenzie practitioners that I know of, we'll leave it at that, don't really teach passive physiological or passive accessories because of the concept of empowering the patient to treat themselves. And we have no problems with that either. Maitland therapists, we want to get the patients self-treating as soon as possible. And the treatment we give them is driven by what we see in the clinic, just like the McKenzie guys, right? Guys and girls. So in parts of the world, McKenzie teachers are teaching active physiologicals, passive accessories. In other parts of the world, passive physiologicals and passive accessories are not being taught. My question, the $64,000 question, is why? Right? Mm-hmm. Based upon that little clinical vignette we just talked about, mm-hmm. right?
Mm-hmm. Okay.
Does that make sense?
Okay, now I'm going to ask you a controversial question.
Go for it. So we're going to make lots of friends today.
So when you are spending time with McKenzie, how did you see him practicing? If there is these, different lines of thoughts.
He was not different. he was doing exactly what I've spoken about today, yeah, about Maitland. Understanding that Mackenzie, Maitland, Mulligan, Paris, many of the modern, Carlton-Bourne too, many of the modern approaches to manual therapy either read or studied directly under James Cyriax. If you look at the genealogical tree of orthopedic manual therapy, the core of that, of modern day manual therapy, is James Cyriax. And you guys know Cyriax techniques, they just got rebranded to a new name. So something like a Cyriax friction massage grip, which I'm doing on the video, I hope you can see that.
Mm-hmm.
Yeah, that's a Cyriax technique, right? Selective tissue tension, okay? Full contraction, pain-free, full contraction with pain, minimal contraction, no pain, minimal contraction with pain. Those were Cyriax concepts. So the modern manual therapy milieu, the modern manual therapy masters, the Mackenzies, the Maitlands, the Parises, the Mulligans, and others, Carlton-Bourne, Evian, others, Grimsby, they all took on board the Cyriax components and then refined them into their own approach. Look, I'm not a good chef. I'm a good cook, but my wife is. But she makes fantastic bouillabaisse, right? I make really good toasted cheese sandwiches. That's my skill set, okay? But she makes really good bouillabaisse. And it's different from someone else's bouillabaisse because she has special ingredients she puts into it, right? So there's no harm, no foul in taking something that's from another approach and melding it into yours and making a new dish, a better recipe. But as a 61-year-old staring down the barrel of 62-year-old, oh God, what am I going to do? As that, my most important responsibility in the world, beyond my wife and my kids and my family and my community, etc., is to ensure that the Maitland approach, that Jeff Maitland's works, don't become marginalized and lost to antiquity and reinvented, so much so that they don't really bear resemblance to all the important principles that are encompassed within the Maitland approach.
And
Does that make sense?
Yes. And I was thinking about the rationale behind, because it all seems like very similar in the sense of like you look for a baseline, you find a way to improve and recheck the baseline. And I think the common sense says Mackenzie is active, Maitland is passive. Those big, the when people describe the methods. And like when I'm talking to you, I'm understanding better that it's more similar than what we think. And even with, I have taken courses with more experienced MDT instructors, and they put overpressure right away in certain joints, in certain specific situations. They mobilize to find a level before even they do some active movements, or they do overpressure on the extremities. And they go quicker and where they need to go, instead of just starting with the patient generated forces. So I'm here trying to just think really the difference when we think it's active passive, but in the end it ends up being a lot more similar than what I think people think.
Right. And so the exercise that let's take that patient with the extension problem, right? So so there's Mackenzie light, okay? Mackenzie light, everyone's got to do extension. Maitland light, push on it till it hurts, right? Now we're deeper than light. Now we're going into the philosophies of these great individuals, right? This is what I would do with that patient, is I would do the mobilization at L4, sit them up and reevaluate, and then I get them to do Mackenzie extension as their home exercise, right? On day one, that's what I'm giving them. Yeah. I want to get patients independent as soon as possible, But unless I attend to with my fingers and my elbows and my rotations and stuff, unless I attend to the limitations that they already have, they can't do that exercise, no matter how diligent they are, no matter how motivated they are. They simply can't do it. So we give home exercises on day one, right? And then when they come back on day two, this is my question. So let's say I saw you for a neck problem or an elbow or a shoulder, whatever it is, doesn't matter. So I'm going to send you home. I'm going to give you an understanding of the pathology in a way that you can understand it without getting buried in medicalese, right? I'm going to give you an understanding of what the condition is. I'm going to empathize with you and I understand how difficult this problem is for you, for your lifestyle with a new baby that you're nursing and bending over, etc. So, what I want you to do tonight is I want you to go home and I want you to just rest, okay? I'm not going to give you any exercises right now. I want to see what it looks like this time tomorrow. Because an important concept in Maitland is irritability, okay? And what is irritability? How much activity causes how much symptom provocation, and how long does it take to settle down? It's not a pathophysiological concept. It's a patient-specific concept. Somewhere in there may be CBT, cognitive behavioral therapy. Somewhere in there is pain science, right? Not just mechanistic tissues moving against tissues. But how much activity causes how much symptom provocation? How long does it take to settle down? When they come back the next day, my question's going to be, hey, Mariana, how did you feel when you left my office? You know what? I felt a bit better. Good. How long did that last for? Yeah, it lasted for like 4 or 5 hours. Started to get a little sore later in the day. I put the ice pack on it, like you suggested, and that helped calm it down. I actually got a good night's sleep last night. I slept well. I woke up this morning and it was stiff again. It was sore, but it wasn't the same kind of soreness from before I came to see you. And now I'm back, and I'd say it's probably like, 10, 15% better than when I first came in. Great. That means that Mariana is non-irritable. So I can start going further into range and resistance and really change things quickly. And now I can give her a home exercise which will augment what I did in treatment. If my treatment, I'm going to swap for a second to an easier movement. I'll do it with neck. Okay, let's say I've got a limitation turning to the right. Ow. Ooh, that hurts. Ooh, that hurts. Ooh, that hurts. All right, well, doesn't take 6 years and a doctorate to say, then don't do it, right? But let's say they're a pain-dominant patient. I want them to have as much range as they can without causing the pain. So every hour, on the hour, set a timer on your phone. Beep, 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 beep. Great. I want you to do 5 of those. Go as far as you can without hitting the pain. That's for a pain-dominant pathophysiological patient. For a stiff-dominant patient, I'm going to say, I want you to move it into the pain. I don't want you doing anything like this. I want you to just move into the pain. Try and keep that moving. Because we gain some range in treatment, I want to keep that range through your movement. So that's the exercise they're going to go home with, and it's specific to their condition. It's not a sheet that I print out and say, here, do all 12 of these. One of the tricks I've been using recently is I borrow their cell phone, and I say, hey, I want you to, unlock your phone, turn on your video, okay? I'm going to hold the video to you so you can see this exercise I've given you to do, and I'm going to instruct you on how to do it. Yeah, that's right, that's good. Great. Okay, so here's your phone back. So it's not a HIPAA moment. I don't have a recording of it. Here's your phone back. That's the exact exercise I want you to do. So when they come back after the weekend and they say, yeah, I'm no better. And you say, well, show me, leave your phone there and show me your exercise. I don't know. It's something like this, isn't it? No, it's not that. It was this. Okay. So look, we're a team. I'm trying to get you to the Olympics. All right. You're the athlete. I'm the coach. If we're not both doing our job, we're not going to make Olympic gold. So you need to determine whether or not you are committed to getting well and take responsibility for doing the exercises as I prescribe them. If not, then thank you very much. We're done.
Yeah.
Fair enough?
Yes. And as you were talking about the stiff that's going to touch the pain, then I remember about one of the principles: you produce the pain, but you're not worse. So like on the McKenzie, so the more you talk, the more that I start to connect the things, and the goal, it's the same, is to make the patient active as soon as possible so they can self-treat. So it's just different ways to get to the same goal. You're just using different techniques, different approaches to get to the same goal. Because some people can just think, oh, it's passive, so the patient is going to be dependent, and that's not what you're thinking here. You're thinking about empowering them to self-treat as well.
Absolutely. It's passive, but it's not inactive. How's that? Yeah. It's not placebo. It's passive because the therapist is doing it with their fingers or their elbow or whatever it is, their hands, right? It's passive, particularly in the accessory movements, because the patient doesn't have the muscles to do the accessory movements. There's no way they can make the accessory movement move. That's where, no matter what happens with, remote therapeutic monitoring and AI looking at what every physio does and all that stuff that's going on, there's always going to be a need for people with good hands who can reduce pain quickly and help the patient to regain function quickly.
Yeah. And so how do you treat? It's basically more the mobilizations. What are the techniques that you use? And then when you send the patients home, do you teach them self-mobilizations, manipulations, or is active movement? So how does it work?
Okay, mobilization and manipulation. Let's go there first. Most Maitland therapists do mobilization first, and then, if appropriate, use manipulation. That is, mobilization non-thrust versus thrust manipulation. We have a cult of cracking going on in recent years. Everyone wants to, everyone wants to go do a course where, so what's your differential diagnosis? Well, for this one, I'm going to do dry needling first and then manipulation. But for the other one, I'm going to do manipulation first and then dry needling. Oh, okay, fine, I get that. So we got a lot of people teaching manipulation. We got a lot of people doing manipulation. Most joints don't need to be manipulated, is what Maitland said, and I agree with. And rational manual therapists agree that many joints can't be manipulated. For example, okay, I'm a student of orthopedic manual therapy and particularly of the history of it. So if you look at Philip Greenman, osteopath from the US, if you look at McKenzie, if you look at Maitland, if you look at Mulligan, if you look at Syriacs, if you look at Carlton-Bourne, if you look at Stoddard, if you look at Manel, if you look at Laurie Hartman, if you look at Boudillon, if you look at any, and if you look back in history, Hippocrates, the Assyrians, the Chinese, the Turks, etc. If you look back, they didn't manipulate the glenohumeral joint. To make the distinction, there's a difference between relocating and anterior dislocation of the glenohumeral joint. But all of those other philosophies of manual medicine did not manipulate, that is, thrust manipulation, to the glenohumeral joint. Why? Because they knew that it's an inherently unstable joint. It has enormous range of motion and degrees of freedom, and it's held together basically by its capsule, right? And the glenoid labrum, which helps to increase the size of the glenoid, right? Compare that to the hip. The hip is a well-contained socket. You can manipulate the hip. It's unlikely you're going to do a lot of damage, right? So all those classic philosophies of orthopedic manual therapy said, no, we're not going to manipulate the glenohumeral joint. We'll do an articulation. We'll do a mobilization. We'll do a suspension. We'll do a distraction with traction, but we're not going to manipulate it, right? So most Maitland therapists, I would say, adequately trained or have a reasonable understanding of Maitland, spend a lot of time doing mobs and then mobilization, then do manipulation as necessary. In Maitland, we have a thing called a movement diagram, and this is way too esoteric to go into great detail. But in a movement diagram, we are plotting what we think we feel in that patient's joint movement. And it starts with R1, the first onset of any resistance, and it goes to R2, which is the maximum. R2 on a movement diagram should be at end range physiological. So for me, in a 61-year-old man, should be about 180 degrees or so of shoulder flexion, right? What if I was a 13-year-old gymnast? What would you expect my physiological range to be? It's going to be a lot more, isn't it? Okay. Or a dancer. Okay. Or someone post dislocation injury. Okay. So whether or not we use manipulation comes down to our palpation of comparable sign, that patient's pain reproduced by the movement, whether or not that comparable sign can be treated with mobilization, or it's kind of recalcitrant. I mean, I go to manipulation when I've done a couple of bouts, BOUTS, say a minute or so of that, sit them up, re-eval, it's not so good. It's not bothering them, but I'm not getting my bang for my buck. Sit them down, try again. Yeah, you know what? I'm not getting what I want. I'm going to check their precautions and contraindications. It's a safe situation. I have no problems. I'm going to go ahead and manipulate. There are certain special areas like the cervical spine, as everyone on this call probably knows, that are problematic. And so the proponents of lots and lots and lots of manipulation will say, oh, well, it's very rare. Yeah, well, it is rare, okay? But it's rare. And when it does happen, it can be devastating in its circumstances. I recently updated our CAD VBI module for our courses, and I went out and I found Katie May, who died in 2016, I believe. She was a Playboy model, and no, it wasn't 2016, it's later, maybe 2019, because she was a rock star on like Twitter and Snapchat and stuff, right? She was a social influencer. She had neck pain. She went to the chiropractor. She or it manipulated her. She had headaches afterwards. She felt terrible. She went back and saw him. Oh, she reported dizziness, falling over, and losing consciousness to her parents. They called 911. She had 2 manipulations. They called 911. She was admitted to hospital. Look her up. Katie May. Okay. Died of chiropractic manipulation within the last 5 years in California. Take a look at Caitlin Jensen. Just May of 2023, some lovely donor gave her a house that fitted her needs. She had finished her exams in getting ready to apply to go to college. She went for a routine manipulation with a practitioner. I won't mention the name. It's not important. She went to a practitioner. It was a chiropractor. She went to the practitioner, and that chiropractor tore 4 arteries in her neck. And she was taken to the ICU. Look, Caitlin Jensen, Savannah, Georgia, right? So 2023, someone gave her a house because she is a quadriplegic confined to a wheelchair who can't feed herself or speak. And I'm pretty sure she was kind of looking forward to going to college, not that house. Yeah. So it happens, okay? Yeah. So we do the best we can. So we've got the IFOMPT CAD, cervical arterial dysfunction protocol, which was done first in 2012, just redone recently. Out of interest, if you want to go look this up, go to PubMed and do DEBEST, D-E, new word, best, B-E-S-T, just published like 3 weeks ago, showed that the sensitivity of the IFOMPT protocol is 50% in finding pathology. So it's a coin toss, heads or tails. Okay?
Yeah.
So that's the thing about the research. The research changes. That's why we do it. That's why there's 35,000 papers published every year in the English language in medicine and associated fields like us. Research goes on, right? We learn more as we go forwards, right? And that's the point. That's why we stay current and we read. Yeah.
Yeah. Nathan Hudding came here also to talk about that, the the manipulations on cervical and guidelines and help us understand that better. Yeah.
Yeah, look, I really respect Nathan. I think he's a tremendous person and a good researcher. Nathan's systematic review that said that testing is ineffective was 4 papers. Okay. I have a problem with 4 papers. To me, that's not settled science. Okay. One of the papers, 3 of the papers in there assessed the old extension rotation, which is that and that, sometimes called the Klein's test. One of the papers, Peterson et al., 1996, out of Australia, assessed rotation, which is what the original VBI protocol was. Now, for those of you who are interested in history, the VBI protocol started back in the 80s in Australia with Jeff Maitland writing a paper about it. And then the APA, the Australian Physiotherapy Association, published the first guidelines in 1988, just after I graduated. And I went to an information session, and the attorneys said, look, this is the law of the land. If you hurt a patient and you didn't do this, you lose, no questions asked. I cannot defend you. It's indefensible, okay? So it was drilled into us, okay? So my 35-year career, I've picked up 28 of these patients with positive VBI. I didn't manipulate them. I mobilized them in neutral, so I had them face down in the hole, head in the hole, and I did central PAs or unilateral PAs or transverses or flipped them over and did APs in the neck. I did different mobilizations in the neck, which are controlled, and I'm able to see the effect it has upon the patient without going all the way to manip, right? So, if you're interested, look at that Peterson paper, 1996. What they found is that the sensitivity of the end range rotation test for VBI was low in the 50s, but the specificity, when they compared a group of known vertebrovascular insufficiency patients with an age-matched cohort with a non-age-matched cohort, they found and it wasn't a big trial. I think it was like 23 patients or so. Okay, so it's not big N numbers, but they found a specificity of 100 in picking it up in the patients that they knew who had it. So the argument that I've made and others, and Darren Rivette and others have made, is that the testing for VBI does not give you a get out of jail free card, and it's not sufficient. And the best paper I just quoted says that it's a coin toss, 50% sensitivity, right? Sensitivity should be a good test. Sensitivity should be high in a test that's supposed to be ruling out the disorder, right? So that's okay. The testing itself may be the actual dynamics of doing the test may be enough for you to stop and think about, does this patient require manipulation, or would mobilization potentially be safer in this patient? If in doubt, err on the side of safety. Quote Hippocrates, first do no harm, right? So I've argued, and Darren Rivette and others have argued, and many of our faculty in AUSPT have argued that the act of stopping and saying, okay, you know what, I'm just going to test for this. I'm just going to test for VBI with end range rotation held for 10 seconds, back to neutral, looking for the 5 Ds and the 3 Ns, questioning the patient, asking them a cognitive question, asking them a brain blood flow question, count back from 100 by sevens. 93, 86, 79, right? Not the ABCs, A, B, C, D, E, F, G, H, I, J, K, L, M, N, P. Not something that's an engram, something that requires you to know, that allows you to have an understanding or an inference as to whether or not they've actually got blood flow to their cortex, right? And if in doubt, don't manip, right? So in Maitland, we got 5 grades. 4 of them are MOBs, 1 of them's a manip. Maitland did say, I don't know what he would say today since he's passed on. I don't know what his position would be. Maitland told me 85% of patients respond to mobilization completely, and you don't need to do anything more in terms of intervention like that. We'll talk about that in a second. About 15%, 10 to 15% actually require manips. And to clarify, when I say just require mobilization, in terms of, I think when I do mobilization, I think of Control, Alt, Delete. I got the blue screen of death on my computer, Control, Alt, Delete, restart. I think on a neurophysiological level, that's what we're doing with patients' pain. We're changing the mechanics, right? But that's not the end of it. The next thing that has to be done is to restore exquisite functional motor control. That might just be sitting up at your desk and not having a forward head posture. I need you to do some retractions for me, right? That might be a professional golfer. That might be an Olympic level athlete. We need to give them back. We need to ensure that they have functional motor control. And we have a whole course about this. Functional motor control relative to what they need to do. Whether it's being an accountant and sitting at a desk all day, which is not good, and they should be getting up and moving and exercising and shoulders back and all that stuff, or it's an elite level athlete.
And
right?
That's what I was going to ask you about active movements, if you use them in treatment and when do you use it? So you were kind of
Day two.
Okay.
Day two. I really don't want them doing on day one because they're going to, if I give them this exercise and they do that, and they're like, oh, it's killing me. I don't know what you did to me, but I'm in agony now. So I kind of lost a treatment session, right? So I need to know, because it's a science exam, it's a scientific process, right? Measure the dependent variable, change the independent, and then see what happens to the dependent. If the patient throws in too many other independent variables out there and it doesn't respond the way it would with just the interventions I did, then I have lost some data. No, they get an active movement from me on day two, and that's refined on day three and added to as necessary. Lumbar spinal control, Superman's one leg, one arm out, one leg out, etc. All the things, transversus abdominis. I'll tell you a cute one. I was just grading one of our COMT exams, and there was a question regarding how would you teach transversus abdominis, and the therapist, bless her, she said, I teach my patients, pretend you're at the beach and an attractive person is about to walk by and you want to tuck your tummy in, but you just want to tuck it in so you don't look chubby, but not so much that they see that you're tucking it in. And I was like, that's brilliant. I love that. That's a really good example of how to teach TRA, right?
Yeah.
So that's fun.
And then when you use active movements, you're not just thinking about mobility. You are thinking about strengthening and other things as well.
Yeah, motor control, right? What plane do they do it in? Are they staying in pure planes, or are they doing something out here? Why are they doing something out there? Why can't they do it in there? The comparable sign on day one might be something up in there, but then at the end, so this is where I often use overpressure, and it's classic Maitland. At the end, when that patient's about to leave the practice for forever, but call me if you get neck pain or knee pain or hip pain or whatever, or the shoulder comes back, I'm going to overpress flexion, overpress abduction, overpress extension, overpress the rotation. So end range overpressure to make sure that they're all clear, right? Including that specific comparable sign, right? But it's really patient specific. The comparable sign and the empathy is that we're trying to give the patient not only the benefit of what we can do with our hands, but the education of their own body and the things that are good and the things that are bad to enable them to live their best life. And we have to tailor that to the level of the patient. The little old lady who wears lace gloves to go to church on Sunday is very different from the truck driver or the factory worker who's clowning around with his guys in the bar room, So you have to tailor your language, and you have to tailor your explanatory capabilities, your language capabilities based upon what the person does. The easiest people to treat with orthopedic manual therapy are plumbers, carpenters, bricklayers, builders, electricians, auto mechanics. Those guys, because they live in a mechanical world. This is stuck here. I'm putting that in there. I'm doing that to that. I'm separating that from that. The hardest people are the academicians, attorneys, philosophers. They want to know why. I don't know, dude. You know what? All pain is multifactorial. Let's say we've got a patient. This is one of my favorite examples, okay? Let's say we've got a patient, 22-year-old female professional soccer player for the US soccer team, who does a grade 2 tear of her ACL. But due to personal and maybe religious reasons, she doesn't want surgery. And you need to do her rehabilitation. What technology can we use, naming anyone that you like? Rhetorical question, not putting you on the spot, Mariana. What technology can we use to speed the healing of the ACL? That's a rhetorical. But that patient is not an ACL patient. They are everything that patient is. There's a significant psychosocial nature to this. Is this a career-ending injury for her? We need to look at the what's happened in the popliteal fossa as a consequence of the ACL tear. Is there a Baker's cyst there? Is there damage to popliteus? You know, often when you run the MRI and you quickly go, boom, there's an ACL, she's a soccer player, send her to rehab. You know, is there damage to popliteus? What are her quads like? What are her hands like? What happened at the menisci, right? What's going on in the inflammatory status? When did this happen? Where are we along that inflammatory continuum? The biopsychosocial for this patient's huge, right? And what would be so what are you going to do? You're going to do your stuff, right? You're going to do your PT stuff. As a manual therapist, I want to make sure that it maintains its movement and doesn't. So I would do APs on the tibia and PAs on the tibia and rotations and different variations of those to ensure that she maintains the mobility she needs at the tibiofemoral joint while the ACL heals, right? But what would be the discharge criteria? Is it Cybex or Biodix quads ham ratios as a percentage printed out by a computer? No. What's she going to do when she gets on the practice field? She's going to run straight forward, cut right, stop, reverse, go left. So that would make sense that when you're ready, that should be her discharge criteria, what she's actually going to do when she gets out there and she's starting to train again with the US Olympic team or USA women's soccer, right? So it's all of that together wrapped up in empathy and humanity and a sincere desire to help these people.
And in my question about home exercise program, so like what do you send them home doing? Do you just do active? Do you teach them something that you did passive that they might be able to reproduce, or like what? How do you go about the home exercise program?
Send them home with like a sustained natural apophyseal glide, you know, a movement, mobs with movement, a Mulligan thing. Send them with that. Give them some stuff to do at home. It depends upon multiple factors, as you know, as we've discussed. Give them something proactive that's going to actually attend to their specific problem, right?
Mm-hmm.
Don't just say, look, I know you're a soccer player and stuff. I really think you should be like, like just swimming, just do backstroke. I don't want you to put any pressure through your knees, so just do backstroke, right? And that's meaningless, you know. Oh, it's good aerobic and all that sort of stuff, and it's non-weight bearing, it's non-pressure, etc. It's probably good for it, right? But the point being that the exercise that we give them grows out of what we've seen in clinic. So if you see a limitation, determine if they are pathophysiological, pain dominant, or pathomechanical, stiff dominant. If they're pathophysiological, pain dominant, give them something they can do short of causing the pain, which might flare it up, thus changing irritability. Or if they're pathomechanical, do something that they can do into resistance, like a self-mob, right? Yeah. It depends, right? So at the end of a course, I say, okay, so, and people come up like, oh, great course, really enjoyed it. Listen, I've got a patient, and I'm like, stop. I'm going to give you a one-word answer.
Depends.
Assess. Assess. I can't tell you. I haven't seen them. I didn't see their gait as they walk in. The patient interaction begins the moment you see them come in. There's a 23-year-old hotshot businessman talking on his cell phone, doing big deals on Wall Street. Like, dude, put your phone down. This is not what we're doing. This is therapy, right? Or is it an elderly man? He's on a walking stick. He's having hunched over, thoracic kyphosis. They're very different patients, right? And you have to approach them in very different ways.
And when you are talking about the home exercise program with the techniques that you send them home, doing maybe, some similar to Mulligan, I wanted to ask you about how we talked about Mackenzie and Maitland, and now comparing Mulligan. How do you see that being similar or different from Maitland?
Oh, look, I love Mully's work. Yeah? If you're out there, Mully, I'm thinking of you, brother. I love Mully's work. The one of the things that Mulligan stresses is that it should be pain-free. And I get that, and I try to do that as much as possible. But sometimes when I'm moving a recalcitrant L4-5 segment that hasn't moved in, what did we say, 18 months, 2 years was the example we used before, it's going to hurt a little. It's the pain of stiffness. It's the pain of tissue which is adhesed that needs to be stretched. I would never say to a patient that I'm tearing your adhesions. I would say I'm remodeling your scar tissue.
Mm-hmm.
Yeah.
Yeah.
But patients will say, for any of you who use the symptom provocation approach, comparable sign, concordant sign, familiar sign, just history is important. Comparable sign was first described by Jeff Maitland in 1964. Anything that comes after it is, it's okay, but it's not particularly original. Originality is the ability to conceal your sources. Remember that, right? And I don't mean that as a criticism of any particular philosophy or person, but I think it's important to understand where it came from, the origination, right? So Mulligan likes to do stuff in pain-free range, right? He had a patient who couldn't straighten her finger, right? And she sort of taught that to him, right? She said, I do this, but when I do that, then I can straighten it. And he had an aha moment,
Mm-hmm.
right?
Mm-hmm.
Mackenzie's aha moment, as most of the Mackenzie people know, is that he had a patient on a treatment table and he had the back of the treatment table up. The guy was sitting on the table, and then Mr. Smith came in, and Mackenzie popped out of the room. He said, go in there, lie on your belly, lie on your tummy. And he came in, Mr. Smith's lying on his tummy in extension. And Mackenzie, in his own mind, went, oh my goodness, what has this idiot done? And the guy said, thanks, doc, I feel much better. That was Mackenzie's aha moment. One of Maitland's aha moments was the slump test. Said to a patient, as far as you're concerned, what do you feel is your main problem? And he said, I have trouble getting in and out of the car. In what way? Well, when I bend my head forwards and duck my shoulders and put my leg into the car, that's when I get my pain in my back and into the back of my thigh. He said, can you show me? He said, sure. And he sat on the table and he said, there, I've got it. So then Maitland played with it and he tried to work out how he could tension up the system, tried doing it in supine. It was too cumbersome. So he wrote the paper on slump, which was effectively developed from a case study and the neurodynamic components of it in 1985. And so as you know, the slump test is done on the end of the table generally, right?
Mm-hmm.
So you can control and add components and then take out components. So you slump them down, lift up the head, what happens, right? No, I love Mulligan's work. Mully does great stuff. They're all, remember, we're all
from the same,
that group.
Yeah.
Mulligan, Maitland, Mackenzie, Paris, Carlton-Bourne, Grieve to a degree. They're all like children of Syriacs. They all have that methodological approach. And what they also have is inquisitiveness. Not necessarily looking for, oh, gee, I wish I could find a phenomenon that will make me famous and I'll travel the world and teach about it. Not that. They were inquisitive of their patients and said, well, hold on a second. That makes sense because it happened, but I don't understand why it happened.
Mm-hmm.
I will look for it more.
Yeah.
That's called a clinical pattern, right? That person, that Mr. Smith, the woman with the leg, the slump patient, that's a clinical pattern. And then you look for that. And in Maitland process, we talk about, and throughout the process, we talk about developing clinical patterns in your head, right? And then the next time you see that, the next time someone says, I have trouble getting in and out of the car because then my back hurts and it runs down my butt into the back of my thigh. Take a look at slump, right? That's n equals 2. And when n equals 5, n equals 50, n equals 100, n equals 1,000, then you have a number of clinical case presentations or clinical patterns that you can draw upon from experience. And unfortunately, I can't give you experience. You just have to look. This is for the newer clinicians, right? You just have to look. You just have to assess every patient. And as you assess and you get good at your subjective exam, your questioning, and as you get good and efficient with your physical exam, it doesn't have to be time consuming. It doesn't have to be long. Okay? It doesn't have to be this long, drawn out, okay, I need an hour for this patient who's got hallux valgus. What are you going to do for an hour with a patient with hallux valgus? I'd be lost after about 7 minutes. I'd be like, I don't know what else to assess. I got everything I got. Let's go. Let's move it.
Yeah.
Right?
Yeah.
Yeah. Makes sense?
Yes. Chris, we talked a lot about a lot of different things. Before we transition to the final questions, anything else you want to add to our discussion? Anything that you want to mention when we haven't talked about?
Oh, yeah. You know what? One of the things I wanted to talk about was, we talked about passive accessories and we talked about the comparable sign, its provocation testing, and it's valid, and it is valid. One of the things I wanted to talk about, because some of the philosophies, as we've talked about, don't necessarily do central PAs, and I'm going to talk about lumbar spine just to give you an example, right? Don't necessarily do central PAs, which is a passive accessory, right? Or PIVMs, passive physiological movements, right? And so I just want to give you some thoughts here, okay? So the central PA, jockey on the horse pushing down on the L4 that we talked about, that has a sensitivity of 92. And for facet disorders, it has specificity of 95. And it has a positive likelihood ratio of 8.6. So normally we're looking for a 10 for it to be really, really good, right? But we combine them together, right? CPA has a sensitivity of 92 for pain coming from that segment. Yeah, a number of papers have discussed it as being the best diagnostic test for instability. The Julie Fritz 2005 CPR for lumbar instability used positive CPA, greater than 53 degrees of flexion in the lumbar spine, and that resulted in a positive likelihood ratio of 12.8 for lumbar instability. And we're still using that today. That's one of the few CPRs that was actually validated, right? The other thing to think about, a lumbar PA, what does it do? It significantly increases straight leg raise movement more than doing ham stretching. That's SLESAC 2011. They're superior to prone press-ups. Sorry, guys. In terms of restoring extension, okay? The central PA was better than a prone press-up. You're going to ask me for a reference. I'm going to give it to you. SHAH, S-H-A-H, 2016, yeah? And lumbar PIVMs, actually getting the patient in sideline and palpating for movement, flexion, extension, side bend, rotation. Lumbar PIVMs have specificity of 97 to 99. The sensitivity and specificity numbers I'm giving you are from Chad Cook's book from 2013, Cook and Hegedus, Orthopedic Diagnostic Testing. Okay? So if you haven't been doing PIVMs, try them, see what you can learn. If you haven't been doing PAVMs, passive accessory intervertebral movements, or PAMs, and AP in the shoulder, do them. Yeah?
Try it. Give it a chance.
Try it. N equals 1, right?
Yeah.
Then it's 2. Then it's 5.
Yeah.
Now you're learning. Now you're progressing. So now you're a thinking clinician, not a robot following rules. right? And then you're open in your assessment and treatment of patients to recognizing those aha moments, which become your aha moments. You know, there's an old saying that old people like me in professions say, show me your new technique and I'll tell you what we called it 35 years ago, right? So it's not highly likely that you guys are going to be developing, the whiz-bang technique by Dr. Whiz-bang and et al., but it is likely that the more patients you see and the more you evaluate patient movement, that your palpatory skills get better, your patients get better, and you develop more clinical case presentations in your head, which is clinical experience, which means that you can quickly identify them when you see them come into your clinic, which means you're the go-to in your clinic. Oh, you've got to go see Mariana. She's the expert in that.
Yeah, and you just know what they're going to respond to quicker. You start identifying the ones that are going to respond to X, Y, or Z and go straight to it. Yeah.
Right, because what's the holy grail of lumbar spine pain, right? Patient subgrouping, right? That's what it's all about. Everyone's trying to find the patient subgroup that will get this, or this, and how do we divide them into that group? And probably the greatest confounder in that, the greatest confounding component is what happens inside here in the brain, yeah?
Very interesting.
Anyway, sounds like you want to wrap up.
No, I'm good. What else?
So, what else? What do you want to talk about?
No, I think we covered a lot of things. Anything else that you wanted to mention?
No, I think we've covered some good ground. Happy to do this again sometime. Do people email you, Mariana?
They do.
Okay, so maybe we do this some other time and answer some email questions, right? Maybe we stimulated some thoughts.
Yeah.
Controversial and otherwise.
Come back to another round of controversial.
Yeah, why not? Why not? Well, no, if you just follow the status quo, you're just going to follow, right?
Yeah.
Be controversial, but be honest, be truthful, and be respectful.
Yeah.
Right?
Yeah.
Unlike the current political dialogue in the United States, right?
I think you just have to be open. The goal is to help the patient, right? Whatever it takes to help the patient, be open to trying different things and what works.
Absolutely.
What works best.
Absolutely.
Works best.
Yeah.
Chris, resource of information, anything that you recommend our guests to go to take a look, any books, papers, anything that you like in particular?
Well, okay. So this is how I got to pay the bills. So go to ospT.com. Take a look at our courses. You could do a course. The other thing you can do, you can go to ospT.com. You can look for our research commentaries. They are free, okay? We do capture your email address, as everyone does these days, but that's just because we want to understand who's looking at it and what they're doing with it. There's 97, I think there's 98 now over the last 10, 12 years, and they cover a bunch of these topics we talked about today. They're written it's a very brief discussion, and then I actually give you a hyperlink to the paper if it's not an open access. I've been choosing open access a lot more recently, so I can actually give you a PDF of the paper. So I give you sort of an overview of what I think the importance of this paper is, and then you look at the paper. They come out roughly monthly, and they're free. So research commentaries at ospT.com. Take a course, not just our courses. Take another course. Ask yourself the following question. Did that course have the instructor evaluate and treat a live patient in front of the class? Because I know we do. We do it at every course, whether it's a patient pulled. And we don't tell the clinical facility like, this is the exact criteria of the patient I want to see. We just say, just find someone with a shoulder so we can see him on Saturday afternoon. Just someone who's on the regular schedule for shoulder. I'll do the assessment and treatment. I'll throw the rubber on the road. I'll show you exactly. Because you go to a course and like, with the slideshow. And they're like, well, there you go. And it's perfect.
Yeah. Real life situations.
Yeah. See a patient, a cold open patient. I don't say, send me their MRI and their chart and all that sort of stuff. I just want to see a real patient. Let's see how it works.
Yes, that's very good. And any advice to clinicians that are starting their careers?
Don't be afraid to learn. Don't be afraid to make mistakes, right? We learn more from our mistakes than we do sometimes from our wins, yeah? Be inquisitive. Be proud of the profession you've chosen, and always have the patient's best interests at heart, not necessarily your own.
Yes. And that plays in that be open to new approaches, new techniques, anything that's going to help your patient.
Absolutely. Anything that works.
Yes.
Anything that works.
Chris, thank you so much for your time and coming, share all your knowledge and, discuss all these points. It was really good. I learned a lot with you, and I hope that the listeners did too. I'm sure they did.
If they're still awake, that is, right? Some of them have nodded off. Yeah. So, Mariana, thank you very much. It was a great pleasure. Thank you for having me. I enjoyed doing this. And to the audience, thank you for attending. And I hope you found something meaningful in just one little meaningful scrap in all that garbage that I spouted out.
It was really good. Thank you, Chris.
Thank you, my dear. Take care.